Sorry. we can continue later on after the symposium. This was an excellent introduction for sharing experiences from all over the world, and then I would like to share with you my team experience. Here it is. So the development of knee replacement must not hide the many advantages got from the high TIBIAL osteotomy, the treatment of various knee arthritis. And we would like to share with you our results and indication after the long-term follow-up. So, as Hatim said, we should have a good radiographic evaluation before operating, and we also should have a kind of classification, which is the one we use is based on that of Ahlbach, a little bit modified. We also have to study our criteria before operating, because we have to stress on the various deformity of the tibia, and to see that we really have a competent medial ligament plus an adequate lateral joint space. We have to check the narrowing of the medial compartment, as well as to check the mechanical axis, which would be medial to the medial compartment itself following Jacob. Our aim is a preoperative planning, restoring axis angle of 2 degrees, plus an overcorrection of valgus to 3 degrees, that is 5 degrees. So this is just a reminder of the opening wedge addition and the closing wedge classical operation. And sometimes we make a kind of morselization of the inner part of the resected triangle in the closing. And this is our series of 237 knees with a follow-up of 15 years, 0.5. Most patients are female, and their median age is 55 years. I think this is not an old age. It's median age. 55 is quite young. So we have 2 series, one of opening and the other is that of closing. 128 knees, opening, with a median initial ASSS score 99 points out of 200, and medium initial varus was 13 degrees. In the closing, we have 109 knees with a medium initial HSS score of 91, and the medium initial varus is only 11, because this is due to our indications and the selection of the patients. Among the 237 knees, we had 35 reoperations, either for HTO or total knee arthroplasties, and we had also some other complications, such as interarticular fractures. In the clinical results, we mainly note that pain is still here, and let's say more than 12% of the patients. These are our clinical findings based on the HSS scoring. And as you see, oh yes, there is an error in the post-op. The 99 should be green, and the 81 should be in pink. Our radiological findings, the bone healing delay after opening is the 70 days, and after closing it's the 55. This is classical. And the obtained average valgus angle is after opening wedge osteotomy after 15 years is 2 degrees remaining, and after closing only 4 degrees remaining. So these are our global long-term results. With 42 good and very good results after 15 years. This is a case, first case we would like to illustrate with. 62-year-old man, left knee medial meniscectomy, who had 2 years later a closing HTO for left knee 7 degrees varus and osteochondritis. In 1997, he had a closing osteotomy in the right knee. And at the last follow-up in 2008, he was still satisfied and active, working without crutches. Meanwhile, his left medial condyle osteochondritis healed, even though the arthritic radiological aspect kept worsening. Second case is that of 63-year-old woman with a right leg opening HTO, which was quite satisfying, which had quite satisfying medial compartment for many years. And in 1999, the right medial joint space was still looking quite satisfying, but her left knee also necessitated a closing HTO, which was complicated by a tibial metadiaphyseal mismatch visible in 2002. 4 years later, the knees were slightly painful and the patient was using a cane. Last case is that of tibial diaphysis malalignment with painful right medial osteoarthritis. He had a closing HTO with good clinical result, but there was a recurrence of the joint space narrowing. Thanks to the Knee Society rating, this is the comparison between the opening and closing HTO at 15.5 years. One can see that there is a decrease of good results with time. Many authors submitted that both techniques of opening and closing wedge osteotomy lead to comparably good clinical result, and this is to answer the question that has been put earlier. And the one who said that is Philippe Pernigot is here, and will be talking after. Nonetheless, in our series, there were 5 findings worth to be noted. First, the total of the 2 KS scoring out of 200 after intervention was 99 for opening and 91 for closing wedge at follow-up. The chi-squared test on the previous results derived a p-value which was higher than 0.05 with a p-value of 0.159. So one can therefore assume that the interventions using the opening technique do not give significantly better clinical results than those used in the closing technique. However, given the level of the p-value, the latter gives more suggestive rather than significant better results. Second point worth to be noted is that the post-operative classification has improved slightly in both series and showed aspects at grade 1, 30 cases, and so on. The chi-squared test on the previous results derived a p-value which was slightly higher than 0.05. So one can therefore assume that a surgical intervention after 15.5 years does not give significantly better clinical results than no intervention. However, given the level of the p-value 0.118, the latter gives more suggestive rather than significant better results. In addition, the initial KS scoring was somewhat lower than that of the closing wedge, while at follow-up, the KS evaluation was slightly higher. Therefore, we think that a slight preference for the opening technique should be considered since the opening technique was applied on bigger mechanical axis angulation That's 13 for opening and only 11 for the closing technique. Finally, in the literature, a whole set of statistics shows that the open wedge HTO seems to be more predictable for correcting various deformity of the knee, as seen here in a picture which has been taken from a book written by Coscino. So, satisfactory pooled results from different centers show that 85% at 2 years, 75% at 5 years, and only 40 to 60% at 10 years. This is in favor of the decrease of the good results. There are a lot of risk factors that should be studied before the operation. And these risk factors associated with failure of osteotomy are age, obesity, high adduction moment, subluxation greater than 50% loss of joint space, laxity, limited motion, and technical error are also found, such as in the correction, etc. So, the 10 to 19 years survival rate of properly overcorrected knees after HTO is better than that of many series of knee arthroplasty with the same follow-up, as said by Odenbring. So, how many degrees of hypercorrection should we use? Gautelier in France proposes 3 to 6. Laura, 3 to 6. Hermigo, here. 3 to 12, I found in a paper. Wow, 10. In our series, we use only 5 degrees mechanical, but mechanical axis. So when someone talks about how many degrees, we must always ask, is it mechanical, is it anatomical? And remember the pictures, the drawings shown by Hatem. So our indication a little bit different from that of Hatem, and we think that the ideal candidate, we think with Marty and Verhagen that the ideal candidate of an osteotomy is a patient who has only unicompartmental osteoarthritis with limb malalignment, no flexion contracture, a range of motion of the knee of at least 10 degrees, and intact ligaments and no severe osseous defects. In summary, opening wedge would be for grades 1 to 3 and wide varus angle until the age of 65, and closing is reserved for the medium varus in younger patients. In conclusion, a careful patient selection and skillful surgical technique, efficient intervention if 5 degrees mechanical valgus is found, knees axis restitution plus clinical improvement for 10 to 12 years only, and more severe arthritis is seen after 15 years. So, an early HTO gives good results, avoiding or delaying replacement, and HTO is the best choice for prevention and treatment of early osteoarthritis, and also for cases of beginning or medium severity, and probably, and we can say that in our international society, this could be also useful for economical reasons. Thank you.